Good afternoon, good morning, good evening from wherever you're tuning in from today for another edition of our NSWOCC Walk Institute Continuing Education webinar series. We're so excited to have you on today. And we're in for a really good presentation today on lower leg assessments and the role of the geko device in venous leg ulcers. Before we get started today, I just want to do a couple quick little housekeeping items. Firstly, if you can just click on that chat button in your Zoom toolbar, I'll ask you to type in where you're tuning in from. My name's Troy, and I'm the Director of Operations for Nurses Specialized in Wound Ostomy and Continence Canada. I'm tuning in from Ottawa, Ontario, and I'm joined by our guest presenter today, Dr. Michael Stacey. Before I get into introducing Dr. Stacey, I want to first thank Perfuse MedTech for being able to put on this education today. It's with their support that we're able to do webinars like these, and we sincerely thank them. As you all know, we'll have a Q&A session at the very end of this webinar. And to ask a question, if you can click on that Q&A button in your Zoom toolbar, that'll make sure that myself and Dr. Stacey can see them, and we'll get to them as soon as we get to that portion at the end. The webinar is being recorded, and it will be available to be watched on demand after the fact on our website. So we encourage you to go do that or share with your colleagues if they didn't have a chance to come on today. And finally, you will be receiving a certificate of attendance for tuning in live today. So please stay tuned in your inbox for the next couple days. So without further ado, I'm so excited to be introducing Dr. Michael Stacey today, who's a vascular surgeon who came to Canada from Australia in 2014 as the surgeon-in-chief at Hamilton Health Sciences and professor in the Department of Surgery at McMaster University, also in Hamilton. He completed his medical degree at the University of Western Australia, is a fellow of the Royal Australasian College of Surgeons, and is licensed with the College of Physicians and Surgeons in Ontario. He spent 2 years working at St. Thomas's Hospital in London in the UK, where he conducted his research for his Doctor of Surgery degree. Dr. Stacey took on the role of Chief Medical Executive and Executive Vice President Academic at Hamilton Health Sciences in 2018 until mid-2023 last year. He currently continues his clinical work in vascular surgery and is a consultant for hospitals and biomedical companies in the areas of clinical practice, research, and physician leadership. As well as his practice in vascular surgery of more than 30 years, Dr. Stacey has established active research programs in wound healing in both Australia and in Canada. And he was the first president of the Australian Wound Management Association, which is now Wounds Australia, and the founding chair of the World Union of Wound Healing Societies. Dr. Stacey has a passion for advancing wound care for patients and has previously established a multidisciplinary diabetic foot ulcer clinic and a venous leg ulcer clinic in Australia, and is in the process of establishing a similar clinic at Hamilton Health Sciences. So without further ado, I'm so excited to have you here today, Dr. Stacey. Thank you for giving us your time, and I'll pass over the mic to you.
Great, thanks very much, Troy, and welcome everybody. Very pleased to have you all here to listen to the talk. And what I would just say from the outset, I know that Keith Harding was to have delivered this talk. Keith, unfortunately, is not able to make it today, so I sort of offered to do it in his place. I know Keith very well. We both met at the first European Wound Management Association conference that he ran in Cardiff back in the 1990s. So we're good friends and colleagues, so I'm very pleased to step in and provide this talk on his behalf. Just very quickly, my declarations of interest, including any potential conflicts. So as Troy indicated, I've been involved in wound research for quite a number of years. And over that time, I've worked with a number of different companies on different research projects, currently have 2 consulting contracts. I'm a member of the board of Woundpedia, which is an organization here in Ontario. I have started up a small company looking to commercialize a point-of-care test for the healing status of chronic wounds. And as was indicated, I was the sort of founding chair of the World Union of Wound Healing Societies and just come on as an editorial board member for the International Wound Journal. So really what we're hoping to go through today is to look at the key items that you see on the slide here. And that is to identify the key components of lower leg assessments, to recognize the role of blood flow in wound healing, to have a sense of how geko might impact blood flow in wounds, and explain how geko can impact the healing of venous leg ulcers in a randomized controlled trial that Keith and his group did and then to discuss the implications of geko in clinical practice. So firstly, just to give you a sense of the scope of the problem with wound care globally, this is, a comparison of what countries spend on wound care. And you see in that left column, this is the purchasing power parity, so that you can give a sort of comparable estimate of what the cost is in different countries. And you'll see Canada spends about $9 billion a year on wound care. The UK, which is where Keith's from, is a little bit higher, and you can see the US spends a large amount. When we look at Canada, these are from some published data a couple of years ago, and you'll see the distribution of spend there. You'll see in Ontario a large spend of $4 billion and different amounts as we go around the different provinces. And there's more data on the economic cost of wounds out of England, and I'm just sort of putting up some data from the UK. But the important thing to focus on is that the patients needing care for their wounds, nearly half of those have chronic wounds. About 40% have, acute wounds that need some attention. And the cost per patient is in the region of £3,000 per patient. So the difficulty is that to be able to keep up with the costs, that the healing needs to actually be improved each year so that you can still have the resources needed to treat the same number of patients in subsequent years. And our problem is, we do know as the population is aging, the numbers of patients needing this type of treatment will be increasing. And here, just giving you an estimate of venous leg ulcers in the UK, about £3 billion per year. And as I mentioned before, it's forecast that the patients with these wounds will increase. Various studies quote the range for males and females, or the ratio of males to females. There's a greater number of females, but when we did an epidemiology study in Australia some years ago, when we look at the age-specific prevalence, it's fairly similar in males and females. The reason there are more females with venous ulcers is that women have a longer life expectancy than men, so that's why there is that disparity. And venous disease is really one of the top 10 reasons that patients seek medical care. So a big budget component within most countries' healthcare budgets. I'm going to touch a little bit on the evaluation, and this is based on some work that Keith has done, but also work that I think many people have had involvement in trying to understand how to evaluate someone with a chronic wound. And probably the key is to understand that most wounds will heal without difficulty, particularly most acute wounds. But all wounds do have some potential to become chronic. And the key to successful wound management is to make an accurate diagnosis of the underlying cause of the wound and to treat that underlying cause. There are some specific characteristics that can help guide you as to what the problem might be, what the problem may be that's impeding healing apart from the underlying cause. And it's really important in the assessment to understand those systemic and local factors that can impede the healing process. There is, unfortunately, a small group of wounds that, even in spite of our best practice, will not go on to heal. And what's important there is to understand the goals of those patients so that we can treat their goals appropriately. Just to sort of go into some of the other sort of elements of chronic wounds, there can be multiple complications associated with chronic wounds. There's a long list here. These are not all specific to venous leg ulcers. One thing to keep in the back of your mind is that unrecognized malignancy. There are definitely some wounds that we see that are considered to be venous leg ulcers that turn out to be ulcerating skin cancers. So when we have a wound that's not responding as we would expect, then it's important to review that diagnosis and sometimes to go on and do a biopsy. And then the other changes you see there, osteomyelitis, we see more with diabetic foot ulcers. Contractures and deformity can occur with different types of wounds in different areas. We see that also within diabetic feet, not necessarily because of the wound, but more because of the underlying neuropathy. And heterotopic calcification is probably more common in pressure ulcers than it is in the other types of wounds that we're looking at. And then the last one there, septicemia, can be an occasional reason for a patient with a venous leg ulcer to proceed, to have a poor outcome and ultimately to die. We don't see that happen with venous leg ulcers, but every now and then you'll see someone come in with septicemia from a venous leg ulcer and potentially can be life-threatening. This is just, looking at things that give you a guide as to what the type of wound might be, and this is really just showing you it's the location that's really important and some of the appearance of the wound. So the top left one is a venous leg ulcer, which you see in that gaiter region of the leg. The one on the top right is a pressure ulcer, pressure injury. The one on the left bottom is a dehiscence of postoperative wound, and a diabetic foot ulcer from the dorsum of the foot, from the plantar surface of the foot on the bottom right. So what causes are there for ulceration? There are many, many causes, and there can be a very long list of causes. They're either the key cause or they can be a contributing factor in combination with other factors that result in the wound. So obviously the vascular causes that we're well aware of, the venous, the arterial, vasculitis, and sometimes related to lymphatic system. Neuropathy from various causes, and the commonest neuropathy cause that we see is with diabetes these days. And then other metabolic conditions can contribute to healing, connective tissue disorders. We see often rheumatoid in conjunction with venous disease or diabetes. Maybe scleroderma is the sole cause of some people's ulcer. Pyoderma gangrenosum, we have to keep in the back of our minds. They usually have a slightly different appearance, but things that you otherwise might think might be a venous ulcer can in fact be pyoderma gangrenosum. And then blood disorders, dysproteinemias, all can be contributing factors or causative factors for wounds. The list goes on, and it could go on longer, but we're going to stop at 2 slides. So immunodeficiency from various causes, skin cancer that I mentioned, there can be various infectious diseases, and one that we don't see much these days, but very occasionally you might see a syphilitic ulcer. So I've seen a couple of those on people's feet. See them occasionally from TB as well, on legs. And then sort of other causes that you've got there, other forms of trauma. Radiation is one that we see not infrequently. There are some drugs that lead to ulceration, and self-inflicted wounds also to be considered in this list. Then what's important when you assess the patient is to understand the local factors. So the factors, within the limb or the area that's affected. So there may be inadequate blood supply, there may be increased skin tension, reduced mobility, surgical wounds, not good opposition of the wounds. You may result in wound dehiscence, venous problems. There could be foreign bodies contributing to it. Could be continued infection. There may be a problem with mobility being somewhat excessive over in the region of a fresh wound or radiotherapy. There's some of the local things. And then the systemic disorders, it's really important to understand all of those, and some of them you can correct and some of them you can't, but to have an awareness that these conditions could be contributing to why some patients have difficulties in going on and healing their wounds, and where possible, to try and course correct some of those systemic deficiencies that can go on and impede the wound healing process. And this is just a good example. This is an ulcer on someone's leg in the region of the knee, an unusual location for an ulcer. Some people might think, well, maybe it could be a venous ulcer. It's probably higher than you would expect. There's no venous disease. And in an ulcer like this, unless there's an obvious cause, what you'd be looking at is doing a biopsy, and indeed this is a squamous cell cancer. In Australia, I used to see a lot of these, and indeed have had patients with presumed venous ulcers sent to me by dermatologists, and they turn out to be ulcerating skin cancers. So they can be very deceptive, but should be something you keep in the back of your mind if a wound's not responding as you would anticipate it should. So there is a mnemonic here, the Heidi mnemonic, which I don't really use, but is used in some parts, particularly in Europe. It's really about, the process of assessing the patient. So it's really referring to the history, examination, investigations, diagnosis, and then implementation of your therapy. The key thing with the patient is to look at, all the elements associated with that assessment so that you can come to an accurate diagnosis. And then your treatment will be dependent on what the diagnosis is. It might be things like devices, like pressure offloading devices. It might be compression, bandaging. Some instances, they might need drugs, for significant infection. You might need surgery for patients with some venous disease that's correctable. You need dressings in essentially all patients. And then there are some biologically based therapies as well that one might use. And as I mentioned before, it's important to understand the patient's treatment goals as to what they're expecting out of their treatment and what they're wanting, so that you align your therapy to their particular goals. And then the other really key thing is to keep reviewing the progress, so that you know if it's responding or not responding. And if it's not responding, you go back, you reassess if you've made the right diagnosis. If you've made the right diagnosis, then what can you adjust in your treatment that might actually bring this wound to a healing phase in the healing status? This is expanding on that, and I'm not going to go through this in any great detail, but it's really just showing that, in that assessment, you look at the wound, you look at the patient, you look at underlying diseases they may have, and then underlying factors that might impede the healing process. And then the treatment goals, you look at what the patient really, is wanting to achieve, and then you may adjust your treatment accordingly. And then obviously the review is really key, sort of going forward. And once you do get the wound to healing, how do you actually try and prevent recurrence, particularly with chronic wounds like venous leg ulcers and diabetic foot ulcers? One sort of key point, when you're looking at a wound, if you look at these wounds in this part of the leg where you would think that they're typically likely to be venous leg ulcers, it's really important to look at the wound itself and then the tissue around the wound and what's in the base of the wound. And, what you see on the left slide here is an ulcer with a somewhat irregular border, sloping edges. It's got that pigmented indurated skin around it, typical of a venous leg ulcer. It's superficial, so not extending to the deep fascia. The one on the right, you're seeing deep fascia and some exposed tendon. So immediately you begin to think, okay, it may have a venous component, but this almost certainly has an arterial component, because venous ulcers don't extend as deep as that. And if you see any necrotic tissue in a wound, that might otherwise be a venous ulcer, you've got to think there is an arterial, either macro or microvascular component. It might be large vessel disease, it might be small vessel disease like scleroderma, but just the appearance, should trigger you to think of, what is going on with this wound, because it doesn't meet that typical appearance. As I mentioned before, there are multiple causes of ulcers on the lower leg. And what I'm talking about here is the leg and not the foot, as the ulcers that occur on the foot are predominantly either diabetic or diabetic and arterial, or arterial ulcers. Anything from around the ankle region up to the knee, the most common cause is a venous leg ulcer. However, it's important to understand there are often dual or multiple etiologies that coexist, particularly in the elderly patient. So they may have some arterial disease. They may have other factors like diabetes or rheumatoid that are contributing to their impaired healing process. So when we are looking at patients with an ulcer that we're presuming might be venous, it is important to assess their arterial status. And The common way we do that is with the ankle brachial pressure index, but in more remote areas, you might do it by looking at the wave form on a simple Doppler examination of the arteries at the ankle. And we need to know that if we're going to put in the patient in compression. Excuse me 1 minute. Because we don't really want to cause any harm by adding compression to someone who has significant arterial disease. And for patients with arterial disease, we'll often look at them and think, well, we should potentially revascularize them so that we can then go to optimal compression. Sometimes we can get away with treating patients with arterial disease with lower compression and they'll respond. But if they don't respond, in order to get to full compression, then some form of revascularization of their arterial problems is appropriate to enable us to do that. So these are just some of the typical features that you see, the differences between venous and arterial ulcers. So in the history, you'll have a history of previous venous disease or history of arterial disease with intermittent claudication or rest pain. The location, as I mentioned, is important. The appearance of the ulcer, the presence of necrotic tissue points you to arterial. Exit H usually higher in venous than it is in arterial ulcers. And pain is usually a more significant problem in patients with arterial disease, particularly rest pain, whereas it's present in people with venous disease, but not to the same extent. Edema may also be different, be more pronounced in venous disease. And then the other skin changes, the typical changes of venous versus those of arterial disease. And then obviously the treatment becomes different with compression in the venous ulcer and revascularization for those with arterial problems. And for those that are mixed, as I mentioned before, you may have a combination of both those therapies. And just another point, a lot of the patients that we see with venous ulcers also have edema, and the compression helps with edema. But the real goal of compression is to help improve the calf muscle pump function, because it's the impaired calf muscle pump function that is really the major contributing factor to an impaired healing process. And what happens there is that the pressure in the venous system when you walk normally drops, but in people who have incompetent veins, the pressure doesn't drop. So the pressure stays high all of the time. And so the calf muscle pump is what you're trying to improve with the compression. It will also help with the edema. And then there can be many other causes of edema, as this slide is indicating. And obviously using compression, can help in other conditions and is obviously a common treatment in patients with lymphedema in particular, but can be in other conditions just to control particularly severe edema. And these are just some of the other, causes of edema and just goes through some of the mechanisms. So common things where we see this is cardiac disease, liver disease, renal failure, with fluid retention, and then malabsorption states, venous insufficiency, we know, lymphatic disease, and then it may be more acute with a deep vein thrombosis. So really just in this schematic, just to think of the fact that you've got the circulation, you've got an arterial side and a venous side to the circulation. In the middle, you have the microcirculation in the tissues, and what we're talking about here is predominantly in the skin. And it's really in that microcirculation that you get transfer of oxygen and other nutrients into the tissues. But that can be impeded by problems either in the arterial system, with reduced blood flow, or in the venous system with higher venous pressure. So whether it's one cause or the other, the ultimate impact is to impair that healing process in the tissue. And that's why, from a vascular point of view, we need to consider both of these when we're assessing our patients. And as I mentioned before, not all centres have access to the modern ultrasound that we have in certainly the more populated areas, where there are often nowadays vascular clinics where you can get both venous and arterial ultrasounds relatively easily. And you can't do that in all areas. And a good simple approach, which is a method that Gary Sibbald and the Woundpedia group promoting through the ECHO program, is to use a handheld Doppler and to evaluate the signal itself. So what you're looking for is a multiphasic signal, so either triphasic or biphasic, as against a monophasic signal. The monophasic signal indicates you've got significant arterial problems. And then you can effectively screen out the patients that might have to go seek, further evaluation at a bigger centre. And just to show you as well, we need to have some caution in patients who have what we might think is a venous ulcer on their leg, and you've got an ankle brachial pressure index that's theoretically within that normal range. But if that patient is diabetic, you may be being misled because their vessels are somewhat incompressible. So in diabetics, you need to actually have an additional way of evaluating the circulation, and toe pressures or toe brachial indices are a good way of doing that. There are other ways of assessing the microcirculation as well. And the reason for that is this patient could have what's on the right-hand slide, and this is I think this is a CT angiogram that's basically showing you the stenosis in the femoral artery where that arrow is. But if you look up higher, there's also a problem up in the iliac artery in the back of the abdomen. So certainly it's why it's important to do some form of arterial assessment on patients, even when you think they're meeting the criteria for a venous ulcer, and then especially if they're diabetic. So what about the neuromuscular electrical stimulation? How does that actually work? And then I'll go through that, and then I'll touch on the randomized controlled trial that Keith and his group had performed. So basically, I think most of you know and are aware of the geko device, which is placed over the common perineal nerve on the lateral side of the leg, just below the knee, just below the head of the fibula, which is where that nerve crosses around and goes to the anterior compartment. You can adjust the magnitude of the pulse and the frequency, so that you can adjust it to the point of getting a twitch at the ankle. So it's actually having an active compression of that anterior compartment. What it also does, it stretches the posterior compartment, so it actually improves the blood flow through both compartments, even though its main neuromuscular impact is on the anterior compartment. And there's been a lot of study in this, and when I've looked at the magnitude of the evidence, there is a considerable amount that's been building up over the years. But if you look at some of the early studies looking at healthy volunteers, there's very, very clear evidence that if you add the geko device to those individuals, what you find is that there is an increase in both venous blood flow, arterial blood flow, and also the microcirculation flux. And those arterial and venous blood flows are assessed by Doppler evaluations or ultrasound evaluations in the femoral and popliteal arteries, and flux mostly using some form of laser device to assess the microcirculation. And this is showing a speckle contrast imaging, looking at the microcirculation. This is in a patient with an ulcer. So you see on the left-hand side, that's the baseline without having the device on. You can see a pulsatile effect just from the circulation. The lighter area, I'll just get my cursor, the lighter area in here is where the wound is. And what you're seeing when you've got this geko device on and it's pulsing, you're seeing increase in the microcirculation, both in the wound bed and also in the peri-wound area. And that flux or that flow is increased quite significantly compared to what it is in the baseline. And this is just showing you from a diagrammatic point of view, quantifying the amount of venous flow and microcirculatory pulsatility, so in both the recumbent and the seated position, and also in the wound bed and the peri-wound area. So we're seeing significant increases in both flow velocity and also pulsatility. This is just showing you the diagram demonstrating the blue line at the bottom, which is really the baseline without having the geko device. And you can see the dotted line showing you the mean flux, and you can see the amplitude of the pulsation. The yellow tracing above is showing you what happens with geko. You can see the dotted line is the mean flux, and also the magnitude of the pulsatility. You can see that change there. This is just putting that into some sort of quantifiable method to show the baseline, and with geko, wound bed flux increases, as does peri-wound flux, and also wound bed pulsatility, peri-wound pulsatility also increases. So certainly it creates a significant impact on the circulation in and around the wound. This is also showing you from ulcers with a mixed etiology. Again, at baseline and with the geko device, you're seeing significant increase in those factors as well. This is a small study, but this is showing you effectively again the flux in the wound bed. You can see that increase, which is significantly increased. The peri-wound flux or flow also increases with the geko device. And then the wound bed pulsatility, we see that increasing, and the peri-wound pulsatility also increasing. So certainly a significant impact on the microcirculation, as well as the overall venous flow in the larger veins coming out of the leg, and the arterial flow at the same time. And then this is another example of patients with diabetic foot ulcers, where we see again in this group, you can see that increased microcirculation using the same methodology with that speckled laser. And then I'm just going to do one brief sort of overview of studies that have been done here in Canada. And this is just one study. There are a number of others, but just showing you, what from non-randomized control trials, but real-world experience where you've got patients whose wounds are not healing, and then you move to using the geko device to see if you can, increase and improve the healing. And in this case, these patients' wounds had actually been increasing in size, not reducing. Then they used the geko for a period of 84 days or closure, whichever came sooner. And what they saw, which you can see probably better on this slide, is that before using the geko, the wounds were actually enlarging. After using the geko, the wounds significantly reduced in size. And over that study period, 8 out of the 11 wounds actually went on and healed. So this is giving us a clue or an indication that this is doing something, for these wounds, particularly the difficult wounds. And leads us to the point of, okay, we need, some more evidence like RCTs to be able to support this and, convince the funders that this is something that we should be using in our clinical practices. Before going on to the RCT that Keith and his team did, I just wanted to touch on another assessment method that Keith has been looking at and others have been looking at, and it's really how you assess the rate of wound healing. So if you take these two different size wounds on the left, wound A and wound B, and if you look at the actual total area that's healed, so you can see, if you look at that, it appears that wound A is healing faster than wound B. And then if you go and look at the percentage reduction, it still looks as though B is, in this case, it looks as though B is healing faster than A, because the percentage is a larger percentage of the actual total wound area, and it's just based on the difference in size of the wounds. But if you look at the advancement of the wound edge or the wound margin, so in other words, the distance that it's come from the edge of the wound to the current edge, you can see that looks visibly very similar. And indeed, when you do that, what you find is those two wounds are healing at the same rate. So it's an important consideration when we're doing clinical trials to make sure we've got a a method of measuring healing that's not giving us misleading results. And this is just showing that method that, over time, it's a more linear approach to the change in the wound. And this is just showing you the average weekly wound margin advance. This was in a study of about 40 patients that Keith and his group had done. So now I'm going to go on and talk about the randomized controlled trial that Keith and his group did. So looking at using the geko device in patients with venous ulcers who were having standard of care. So what their basic hypothesis was is that a change in the rate of healing, could be observed when the geko device is added to standard of care. So in other words, these patients are getting what is normally seen as standard of care for venous leg ulcers, which is good compression therapy. They used an interesting design, which I'll go on to in a moment, so a self-controlled study structure, so you can compare the patient's own healing status, but you can also compare between the two groups. And as well as looking at that % reduction, they also looked at the wound margin advance as a check to make sure that they were getting accurate results. So this schematic gives you an outline of what that overall study design is. So patients were screened, they're recruited. So they had what was called a run-in phase for 4 weeks before randomization. So they're in their standard compression, and the compression is a multi-layer, multi-component compression bandaging system of at least 2 layers. And during that time, they could assess the healing rate. Then they were randomized at that point to either continuing standard of care alone or continuing standard of care with the addition of a geko device. And then the treatment phase was 4 weeks, and then they were reevaluated, and then they were followed up to see how things progressed post healing. So this is showing you, again, just breaking it down into those 2 components and just looking at the numbers of patients that were involved in the study. So they assessed 170 patients, 171, 56 failed to meet the inclusion criteria. And the reason for that, is varied, but it may be that the diagnosis wasn't accurate, the size of the ulcers. There are other reasons that the patient may not be able to tolerate compression, etc. So that 115 go into the study. And then they got into that run-in phase, and by the time they got to the randomization phase, there are a further dropout. So one of the biggest reasons was some of the wounds were too small at randomization, so there are 26 of them, just telling us that compression works well in a lot of patients. And some patients, the other big reason was lost to follow-up, and some of it was related to COVID, which is when some of this work was being done. And then the next component is really once they're randomized, then you look at that treatment and you'll see there's a small number of patients lost for various reasons during that study phase or treatment phase. And at the end of the study, there were 29 in the geko group and 22 in the standard of care group. Just to assess the patient groups to see if there's any difference, because sometimes you can get different results because even though you've got a randomized controlled trial, you can end up with larger numbers of patients with particular, parameters. And this is an analysis they did looking at this, and you'll see there's no significant difference in all of these parameters. I think what's important to note is that these wounds were relatively large wounds. Their average size was 10 square centimeters. They'd also been there for a long time. So at the time of enrollment, their average was they'd been there for a year or more. So often what we would consider as, ulcers that really are challenging ulcers to heal and do require, optimal therapy to get them to heal. Ages were relatively similar. So let's look at the results now. So this is the results for those randomized to the standard of care arm. And you'll see what we have is the run-in phase on the left, and this is the treatment phase. There's a slight increase in treatment. So this is the percentage area reduction we're looking at here, but not really a dramatic increase in that period with this group, and we wouldn't necessarily expect it, in patients who are having compression therapy. When we looked at the group that then were randomized to receive the geko, they saw quite a significant difference, a more than twofold increase in the rate at which these wounds were healing. And this is looking at, again, the percentage area reduction. So highly significant increase in healing when you add this to standard compression. So the standard compression patients carry on to heal, but they heal more quickly when the geko device is added in. And this is just looking at it in that different way that I mentioned, where you're looking at the wound margin advancement, just to check that there isn't anything skewed or unusual about the results. But this is really showing the same result, more than double an increase in the rate of healing in those that receive the geko device. And this is just an example of a patient's trajectory. So the top line is the first 4 weeks of running. You can see they're getting some response to compression. And in the next 4 weeks, you can see they've got a much more dramatic response, a more significant reduction in size. And maybe just another comment is that the other thing that was noted in these patients is that their pain also reduced. And they had a high compliance with wearing their geko. Over 90% of the patients were able to wear the geko throughout that 4-week period. So really the conclusions from this is using this novel design, they could compare within patient and between patient groups. And this has been used elsewhere, but it's an important way of analysing the outcomes. You can track the results using that wound margin advance. But what it's really telling us is that with what we're seeing with this is that the use of the geko device is more than doubling the healing rate in those patients that received it compared to the control group that carried on at more or less the same healing rate, through the second part of the treatment phase. So this I think Keith's group sort of concluded that this wouldn't necessarily replace the standard RCTs, but it's a good addition to RCT analysis, so you can see what's happening within patients, but you can then compare between groups as well. And really just to sort of go on as to what's happening with the neuromuscular electrical stimulation device or the geko device. As I mentioned before, there is contraction of these muscles, compresses the vascular system, causes it to contract, so increases arterial flow, but also compresses the veins and increases the venous outflow, therefore preventing conditions that can be associated with venous stasis. It helps with edema. It increases the microcirculation and capillary flow. And it has been other studies, which I've not focused on to any extent here, is that blood flow is increased equal to about 60% of walking. And this is with the patient basically sitting or lying without having to be up and walking. So particularly useful in those patients who have difficulty, getting onto exercise programs. So it's doing a lot of what compression does. It's not a replacement for compression. I think that's really important to understand. But as an adjunct to compression, it actually adds something additional that compression, doesn't on its own do. And by doing this, it facilitates increased perfusion in the wound bed. So what we should be thinking about then is when and where should we use the device? And those patients, who have limited mobility, particularly those with fixed ankles, who can't exercise their calf muscle pump, so should consider them in that group. And those that have not reduced, in what we would normally expect, and often the standard is to say, well, we expect them to have reduced by about 30% at 30 days. And if they haven't done that, we should be, and this is venous patients with venous ulcers with good compression, then we should be thinking we should really be adding in something like the geko device to increase that healing rate. But then I think the additional points are when compression cannot be tolerated. So as we know, there's a good proportion of patients who for various reasons can't tolerate compression, or they can tolerate low-level compression. So adding this to those groups, improves the calf muscle pump function and potentially does then add to their healing ability. It also adds to the ability to get them into high-level compressions as well. Also use it where edema is present, and also, as I mentioned before, it does reduce pain. So if there's significant pain, it may be very helpful in those, with significant pain associated with their wounds. So really, in summary, what I would say is, there is a proven mechanism of action for geko in terms of the arterial, the venous, and the microcirculation in the limb. And what the RCT that Keith and his group have done, it shows that it has caused a significant increase in the rate of healing and the reduction of time to wound closure. As I mentioned, it's more than doubled the rate of healing that we see in these patients. Pain is reduced in these patients. Patients, were adherent to it. We haven't shown you all the data on that, but certainly more than 90% adherence to wearing the device. And this is really with it, adding this to standard of care, that you're essentially getting a larger proportion of patients, healed in a quicker time compared to what you would do with standard of care. So I think, for us as clinicians, it's really important to understand that this does have a real significant role in venous leg ulcers because of its impact on the circulation at all macro and micro levels, and that it's really part of a multimodal therapy. So we're looking at compression as best we can, adding this in as well, to try and optimize the venous return in patients with venous leg ulcers. And maybe I'll just finish off by saying, as part of some work that I'm doing with a group across Canada, we're looking at a consensus statement on treatment of venous leg ulcers. So it's looking at, all of the different elements of assessment, investigation, treatment of the calf muscle pump, treatment of the wound, reviewing and reassessing what you're doing, and then prevention of recurrence. But, things like this device do have a place in an algorithm like that, as do some of the advanced wound therapies, and some of the other adjunctive therapies that we may think of. But I think what you've seen demonstrated through the work that Keith's team has done and through other work is that definitely for patients with venous leg ulcers, there is a significant role for using this device. And I think it's really important that as clinicians, you have that awareness and understand that this is an option to be used in patients at the right time and in the right patient group. This is just a list of references, and this is actually Keith's last slide, because I think Keith usually puts people to sleep. I'm trying not to do that, but I might have done that anyway. Okay, I'll pause there.
Well, thank you so much, Dr. Stacey. That was fantastic. And yes, I think he was presenting at midnight his time at the last webinar there. So hopefully that was the reason why. But no, we seriously appreciate the education you brought us today here. And we do have a couple questions that I know we've had in the bank since our last one, if I can start with those. One person, I know you covered it pretty well in some of your last slides here, but have you personally, or can you speak to any observed improvements in reducing pain and promoting better healing in patients with atrophy blanche with the geko?
Yeah, so no, that's a really good question. Thanks, Troy. Definitely for reducing pain, rather. Absolutely. I think that even Keith's study, but other studies have demonstrated a reduction in pain for patients. And patients who tend to get more pain are those with atrophy blanche. And I think that's one of the things that we've seen. I think probably the data around that is still relatively anecdotal at the moment, but certainly I think if you've got a patient with atrophy blanche or with ulcerations within atrophy blanche, which is when the pain occurs, using the geko certainly is a good option to try and reduce that pain. I think I guess the extent of the data at the moment is probably not large enough to say, which subsets do best, in terms of venous ulcers. But But I think at this point, I think it's pretty strong evidence that it helps venous ulcers. But yes, ultimately, we might even be able to say, look, it helps this group more, and as we get more data out there. But there's no doubt at the moment that I think for people who've got painful ulcers, particularly those in areas of atrophy blanche, this is a good option to consider.
Thank you for touching on that, and I think that really covers it well. We have quite a few comments in the chat there that I'll get to as we go through the presentation. Just a quick reminder, if you do have any questions, to put it in the Q&A box. We'll be able to sort it out a little bit easier there. I just see that Jeff had responded to this question, but if you can just quickly touch on it as well. Have studies been done using the geko without compression?
Yes, I mean, I think a lot of people have used the geko, in patients who are having problems. Sometimes they can't tolerate compression. Have there been RCTs? Not to my knowledge, but Jeff may be able to add to that. I think there've been more, single arm studies and individual case studies. So there are a series of cases where patients can't tolerate other treatments, often not necessarily venous ulcers, but patients with significant edema, where adding the geko has actually provided significant improvement for them. But Jeff, did you want to comment?
Yeah, I think, Michael, my response was that the bulk of the studies on the geko device have been done without compression. That's because the device is used for a lot more than wound care. The DVT prophylaxis studies, the renal transplant study, for example, are a number of areas where the device is used without compression.
Yeah. No, that's a good point. I think, though, when we're talking venous leg ulcers, I think it's still important to think of this as an adjunct to compression, not as a replacement for compression. I think that's really important for people to do that. And even with patients who can't tolerate compression, either they can tolerate low compression or no compression, by adding the geko, what you're still trying to do is to move them to a point of optimizing compression. So what you're looking at is really having the two therapies to help them heal their wound rather than a single therapy. And to Jeff's point, it's been used in a lot of other areas where compression is not your appropriate treatment. And so, for sure in those cases, non-venous leg ulcers, then yes, lots of studies or small studies or case series in those groups.
Thank you for touching on that. And I know we're getting tons of great questions coming in here. One, it's asking from a couple different people here. Can you just speak to whether the device needs to be worn continuously for 24 hours and whether it's intended for single person use only?
Yeah, so I can touch on that, and Jeff might like to add, but basically it's a single person use. And I think when they're provided, they're provided as a couple of weeks worth. A single device usually lasts a couple of days. You don't have it on active 24 hours. Some people have it on for 6 hours, some for 12 hours. I think in this case study, they use it for 12 hours. But yeah, they're single patient use basically. But Jeff, did you want to comment some more?
Yeah, I think there's a couple of points there. If the question is economic based, this is being analyzed by an economist, and in every single scenario, it's very cost effective. And that's also been repeated in a number of the home and community care support service regions in Ontario. I should say 2 of them. If it's related to waste disposal, it's dramatic reduction in waste because this is entirely recyclable. By the nature of product development, you start with a certain design, and over time you evolve it to fit the ideal parameter. These type of patients would probably benefit from an implant because it's a chronic condition, and we do have intellectual property in that area, but it takes about 10 years to get a product like that to market.
Thank you for touching on that. We've got a couple other questions coming in here. One is talking a little bit about the wound margin advance. So this person is asking, how reliable is the assessment of wound margin advancement between different raters? Do you typically select a specific margin and maintain consistency in assessment? This person who's asking is observed venous leg ulcers healing irregularly across the wound.
Yeah, now that's a good question. I mean, the way you assess that advance is that you look at the actual ulcer itself, and let's say at 1 week and at the next week. It's not a case of just measuring in any given area, but you're looking at the average wound advancement with that whole wound. So one of the ways of doing this is to look at the area of that wound from 1 week to the next, and then looking at, so what does that mean in terms of the advancement of the whole edge? So it's putting it into a model that's telling you what that area tells you about how much the average advancement is in the wound. So using a standardized process like that, it should be very similar, because all you're doing is you're putting in your wound measurements and it's telling you what the average wound advancement is. Now, does everybody use that exact same method? I think ultimately people will. I'm not sure that everybody does at the moment when they do this.
Well, thank you for touching on that. We have another question here, and it was just coming from the chat there. If there aren't any visible ulcers, but the varicose veins are notably large and causing tissue weakness, would you advise using a geko device as a prophylactic measure?
I think you're talking about prophylactic measure to prevent ulcers. Is that? I'm sorry, you're not the one who actually posed the question.
No, but they're mentioning that if there's not one apparent, if there's not an apparent ulcer yet, no.
Yeah. So, I mean, mostly if you think that a patient's got a venous problem, and I mean the way to evaluate that is you need to do a venous ultrasound, so to assess both the deep veins and the surface veins. If the problem is just in the surface veins, then they are generally suitable for some form of venous ablation, be it surgical, laser, or thermal ablation, or sclerotherapy. If they have deep vein incompetence, then you can still get some benefit with treating incompetent surface veins, but it's less. Is the geko an option for treating them at that point? Good question. I'm not aware that people have used it, in a proper evaluative way to do that, but the standard that people would do is either surgical intervention or some form of compression stocking, to try and control the varicose veins, to prevent ulcers. But varicose veins, lots and lots of people have them, and only a small proportion of people get venous ulcers. So I think compression stocking is probably a simpler and cheaper way of, using it for that sort of prophylaxis.
Thank you for touching on it. I know we've got a couple people who are now asking about adhesive sensitivities or allergies to adhesives. Could you just talk a little bit about that? If any of the patients in the studies were sensitive to adhesives, have you run into that as a concern?
Yeah, so I think that is a concern, and maybe Jeff might be able to speak a bit more about this. But yes, there are some patients who, do have a problem with the adhesive, and I know, the companies and other companies have worked a lot on, skin adhesives to make them less allergenic, if you like. But yes, there's always a small proportion of patients who, for various reasons, can't wear it. But what you saw in this study is 94% of people were able to wear this for 4 weeks, which is really telling us there was no significant percentage that had problems with the adhesive, and it was probably only a fraction of that 6% who couldn't comply. But Jeff, do you want to comment?
Yeah, I think the adhesive, all these patients have vulnerable skin. So the device, the one side effect that we do have is a rash that forms, and the gel is the area that we spend the greatest amount of R&D money on, because that is the one area where the rash is forming. It's rare that a patient has to discontinue the device, but there is certainly it is our one side effect.
Okay, well, thank you for touching on that. And I'm not sure, Jeff, while we got you on there, did you want to touch on the cost effectiveness of the product in relation to longer term use? I know it's been asked a couple times there.
Yeah, like there's obviously a point where because some of the prophylactic uses that were raised earlier, I don't know that we have cost effectiveness that we can claim on a prophylactic basis, because you'd be using it on a huge number of patients, where some are a maybe for treatment, but certainly when you use it under the conditions that Dr. Stacey mentioned, it's highly cost effective. And there's a paper that's being written as we speak on the economic benefits by a PhD that's done a lot of work in this area.
Thank you. And I've got quite a few questions here. I just wanted to quickly echo what Dr. Pierzynowski was mentioning here, which I'll share, which is saying thank you again for the informative talk. It's encouraging to explore the additional treatments for venous leg ulcers, and the benefits highlight the significance of microcirculation, potentially explaining variations in healing times among VLUs beyond chronic inflammation and biofilm-related factors. He mentioned quite a few other things there, which I've shared with everybody in the Q&A box, but thank you for the kind words there, Dr. Pierzynowski. As we keep going over here a little bit more, and I think either Jeff or Dr. Stacey, if you want to answer, just double checking that NSWOCCs, can they initiate the use of this? Do they have to inform the physician or get a prescription first?
Yeah, so to my knowledge, this doesn't require a prescription.
No.
But the normal thing is to keep all of the providers informed as to what's happening. So you would let them know, but it doesn't require a physician prescription to be able to use this.
It can be ordered by the patient. Bear in mind, this device is used by over 400 teams, professional and elite athletes, Olympics, etc. So it's a device that's very safe to use. There's absolutely no reason for it to be prescription.
Fantastic. And Celine's echoing in the comments here that they, as physios, they often commonly use it in their practice as well. So there you are there. Michelle and I think Tad were just touching on the rash there. Michelle was asking if perhaps the device can be moved to a different position to help mitigate some of that. Is that something that you've seen before?
The answer is yes. We do have alternate positions, because once the rash does appear, you don't want to be stimulating, sending electrical current into an area where there's a rash. So yes, there's different positions you can place the device.
Yeah, and you can still, with that electrical pulse, still, make contact, with some of the nerve at different locations. So you're still able to do that. But I mean, obviously, not radically far away, but certainly, somewhere in the same broad region. And I did see a comment there about the use in arterial disease, which, again, that wasn't the topic of our discussion today, but actually, there has been a fair bit of work looking at patients with arterial disease, particularly those who either are waiting for arterial intervention or for whom, there isn't really an appropriate arterial intervention. And with another group we're looking at reviewing that literature and coming forward with some recommendations on, who of the arterial patients would be appropriate, to have this type of treatment, because we do know it does improve arterial circulation as well and is good at reducing pain.
Fantastic. I'm seeing we don't have any open questions there, but I know, Jeff, you were just responding to one. Did you want to just let people know again where, if there is a direct order site, where they can order from?
Yeah, it can be ordered through Trudell Medical in London, at Trudell Healthcare Solutions.
Fantastic. And so what I'll do now is if there's any last words that either Dr. Stacey or Jeff, if you wanted to mention before we go off today, I'll open the floor to you for a moment.
Yes,
Dr. Stacey?
well, I'll make a quick comment, Jeff, and just want to thank everyone for coming today, and a real pleasure to be able to provide this talk to you on behalf of Keith Harding. And as you'll see, Keith's stamp is all over a lot of this work, and I know him very well, and you know, he does some extremely good work. So I'm very pleased to be able to present it on his behalf.
And I'd like to thank Dr. Stacey. I appreciate you jumping in, and you didn't have a lot of time to prep, and you did an awesome job, so I appreciate it. And Dr. Sybil's on the call, and in 2 weeks he'll be presenting at approximately this time. And I don't know if Dr. Sybil, are you able to unmute and share with the group what you're talking about?
Yep. I can. I'm unmuted, and what we will be talking about is Wound Bed Prep 2024, and we will be looking at this for low resource communities, and particularly leg and foot ulcers, and even how the geko device relates or could help us to improve the healing in these patients. But this is a consensus of 10 statements and substatements that reached 88% consensus. This is from 41 key opinion leaders around the world, and it also includes David Armstrong and Greg Schultz as along with our writer. In addition to this, it will be the CE article in advances. You can go to www.woundcarejournal.com and download the article and have a look at it. It does talk about the audible handheld Doppler as being a simplified ABPI. It talks about diagnosing infection and the fact that oral antibiotics may be used for osteomyelitis, where we might have used IV before. And it talks about simple plantar pressure redistribution devices so that patients in the north, remote, isolated, and indigenous communities can be treated in their own community. So I think what we've got is something that is special. I think it can help just about anybody, anywhere, in terms of if you don't have every resource, that you can treat your patients as effectively and efficiently as possible. And we'll show you how the geko device may also help you. Jeff, is there anything else that I might have left out?
No, I think that's great. I think the fact that that'll be one of the first presentations of Wound Bed Prep 2024, it's a great opportunity for this group to hear that it's available in a couple of weeks. Troy, do you recall the timing of that?
Let me find it for you quick. It's going to be, so exactly 2 weeks from today, it'll be on the, it'll be, on the March 27th, and that'll be from 5 p.m. to 6 p.m. Eastern or 2 p.m. to 3 p.m. Pacific. So it'll be just a little bit earlier than today's time. Do stay tuned. You'll be getting an email in your inbox letting you know of that final registration link. But if you or someone you work with, it might be a colleague on your team or your wound care team, definitely make sure to recommend that they come on as well. Again, it's free for anyone outside of even our NSWOCC organization. So if you are interested in attending, keep an eye out for that. We'll be putting the promotions out in your inbox in the next coming days. So without further ado, I want to thank each of you on the...
Troy, go ahead. I noticed a number of questions on the cost. I think it's important to differentiate between the price and the cost effectiveness, but the price of the device is about $375 per week. So the overall savings comes from shortening the therapy time. I noticed it repeated a couple of times, so I just wanted to make sure that question was addressed.
Yeah, and a lot of the studies were able to improve healing with a 4-week application, so that it's not for everything. And I think, Troy, we're actually an hour later rather than an hour earlier than tonight.
Yes,
that's right. An hour later. Yes, sorry, one hour later. The time zone has got me forgetting how time works again here. The time changes, time zones, but we'll make sure to get all that information to you in your inbox there. So again,
great forward, Troy.
There we go. Well, thank you to each of you for being on the call today. Again, Dr. Stacey, for presenting this great education. We look forward to speaking with you very soon, Dr. Sybil. And again, thank you so much to Perfuse MedTech for making this possible today. We really, really appreciate it. And we'll see you on the next webinar. Thank you, everybody.
Okay, thanks everyone. Take care.
Great.
Cheers.
Thanks, everybody.
Bye-bye.